Welcome to section 29 of the Falcon Physician Reviews Anatomy Online version. Now we're going to discuss the abdominal vessels and the autonomics supply to the abdominal cavity. If you're familiar with these already, quickly move through them just to remind yourself of the organization of the abdominal or aortic branches and some of their leveling. We have the common iliac at the bifurcation point of L4. The renals tend to be at L1, L2, and then we have the gonadal vessels, which will come off as paired vessels just underneath that. Of course, there'll be lumbar segmentals and those vessels that will be going to the renal glands and the suprarenal regions as well. For unpaired, the celiac trunk comes through at T12. Then we have the superior mesenteric at the L1 level, and we have inferior mesenteric at L3. Overlying this at the venous end of things, the bifurcation into the common iliac vein will occur at L5. There's a median sacral vessel coming off the midline. Let's do a question. A 70-year-old man has a 90% blockage at the origin of the inferior mesenteric artery. Despite the blockage, he does not have intestinal angina. Which of the following arteries is the most likely additional source of blood to the descending colon that allows this to occur? You should be thinking of middle colic. The middle colic will connect with the inferior mesenteric via the marginal vessels around the large bowel. In the small bowel, the superior mesenteric is connected to the celiac via the pancreaticoduodenal vessels. And there's an anastomosis around the small bowel, which is called the vascular arcades. We'll see these in a little bit. There are a lot of branches coming off the celiac trunk, all of which seem to orient around the stomach. So if you can come up with all the names of the curvatures and the supplies of the stomach, you basically will have the branches of the celiac trunk mastered. The three main branches are going to be one that comes up, the left gastric, one that goes to the left, the splenic, and one that goes to the right, the common hepatic. The common hepatic will branch into the proper hepatic, and then the left and right hepatics to the various lobes of the liver. The dividing point between the common and proper hepatic is typically going to be the gastroduodenal, which will drop posteriorly and in behind the first part of the duodenum, where it's susceptible to erosions from the ulcerations that we've discussed earlier. This is where it will give off the pancreaticoduodenal anastomosis with the inferior branches that will come from the superior mesenteric vessel. Off of the right side of the greater curvature is the right gastroomental, and then coming up from the left gastrix, there'll be the branches to the esophageal. Now all we have to do is the fundus and the left side of the greater curvature. Off of the splenic, you get the short gastrix running up to the fundus of the stomach. And then off of the splenic as well, you'll also get the left gastroomental. There'll be 3 to 5 branches which run off the splenic into the parenchyma of the spleen itself. As far as the large bowel, it gets most of its blood supply from the superior mesenteric, and it's going to have a middle colic and a right colic. It's then going to give off 11 to 15 jejunal and ileal branches. And then the ileocolic will head towards the ileocecal junction, where it will give off an appendicular artery. That appendicular artery must be tied off during appendectomy. These will have the arcades coming off of them, and the vasa recta will go around the tube of the duodenum and the jejunum and the ileum. As you descend along the small bowel, you can see that the vasa recta start out long in the jejunal regions and get shorter and shorter as it gets closer to the ileal regions as it comes in close opposition to the ascending colon. The marginal arcades will help with the anastomosis should there be any twisting or blockage even momentarily through some of the small bowel vasculature. These will connect with the middle colic over to the inferior mesenteric with the end of the transverse colon and then the descending colon. And we'll look at those momentarily. This slide shows the full anastomosis of the large bowel and its blood supply from both the superior mesenteric and inferior mesenteric vessels. The superior mesenteric with its middle colic will reach around and anastomose with the inferior mesenteric's left colic. That left colic will connect to it with these marginal branches. And there'll be some sigmoidal branches, usually 3 to 5 of those, and then a superior rectal branch that will come off of the inferior mesenteric to supply the upper rectal branch of the bowel. The most susceptible area to anastomotic infarct is, of course, going to be this area where the middle colic should connect with the inferior mesenteric's left colic. And this is where you'll get ischemic problems in the bowel and oftentimes infarct. Another important area is going to be the appendicular vessels, as they supply the appendix and the mesoappendix. These are going to be between layers of peritoneum because the appendix is mobilized through its own little mesentery called the mesoappendix. The ileocolic artery will give an ileal branch, which will then give off an appendicular branch. And this has to be cauterized during the removal process of the appendix. The way you can find the appendix, since it can be in so many varied positions, is by following the tinea coli along the large bowel with its haustrace and saculations all the way down to the appendix itself, because they all initiate off of the base of the appendix. Here you can see a picture of the tinea coli as they'll lead you to the appendix itself with that appendicular artery coming into the mesoappendix. It's also showing a picture of McBurney's point, which is going to be that point that is located 2/3 of the way from the umbilicus to the anterior superior iliac spine. And it's going to be an approximate position of the appendix. And remember what we said earlier, that because of the orientation of the bowel and the potential for malrotations and the length of the appendix, that it can be in many locations all the way from the pelvis up to the liver. The early appendicitis pains are oftentimes diffuse and refer to the midline because it's all visceral. And of course its innervation came to it when it was a simple tube down the midline. Then as it gets worse, the appendix is going to start to irritate the abdominal wall, which is parietal peritoneum, and you start to get a more pinpointable pain. The rebound pain is the referral time that it takes for that visceral or less myelinated fibers to take it back to the spinal cord and then make a cognition of that in the brain and send that signal down. As far as the branches of the IVC, here is a reminder of the vessels and how they drain. Remember, there's a couple things that are important. One is that the right suprarenal and the right gonadal vessels drain directly into the IVC, whereas the left suprarenal and the left gonadal will have to drain into the left renal vein. So occlusion of the left renal vein will oftentimes lead to dilation of the gonadal vessels in that pampiniform plexus that we discussed earlier. The venous drainage of the GI is going to be important. We've already discussed a little bit about the portal system and how it can get backed up, but looking at the actual names of the vessels is also important to have a good idea of what's going to anastomose with what. The most important to remember are going to be those esophageal branches coming off of the portal, which will then anastomose with the esophageal branches that are going back to the azygous system. The portal vein itself is made from the connection of the superior mesenteric vein when it comes in contact with the splenic vein, and that inferior mesenteric is varied in its positioning and can be anywhere along the splenic or up to the junction between the splenic and the superior mesenteric. As far as the branches itself, I've got a graphic that will show you how they connect to one another. The portal veins taking them into the liver for filtration and then collecting them again through the hepatic veins before dumping them into the IVC. What about renal vein compression syndromes? This is sometimes called the nutcracker phenomena, and it can occur when the left renal vein is compressed between the superior mesenteric artery and the aorta. The vein passes in front of the aorta but behind the superior mesenteric across from the transverse duodenum And this is similar to the superior mesenteric artery syndrome, where that superior mesenteric artery can be compressed as well, and that can cause the duodenal obstruction. Now, clinically, it's going to be associated with hematuria, which is going to be blood in the urine, abdominal pain, varicose of the left testicle and the pampiniform plexus, and potentially infertility. There's going to be significant abdominal pain or flank pain, which will be exacerbated by sitting or walking and standing, and the shaking that occurs in vehicles. The gonadal vein pain syndrome and the hematuria are going to be a result of the abnormal communication between the submucosal venous plexus and the pilocalical system, which is presumably induced by the venous hypertension. Now let's focus in on the nerve supply to the abdomen. We've already talked about the different components of the gut tube and the vessel that supply it. Remember, the branches of the celiac, superior mesenteric and inferior mesenteric, are within the substance of the peritoneum or the mesentery as it distributes to the various components of that gut tube. And then the vessels are going to be supplied by the autonomics, and they'll travel along these branches to get to the gut tube. We'll put a kidney onto this, and we'll put sympathetics on one side and parasympathetics on the other, but remember they're both bilateral. The parasympathetics are simple in that the vagus nerve, cranial nerve 10, will travel down bilaterally along the foregut and midgut structures, and then it will distribute to the wall of the foregut and midgut before it terminates and meets up with the S2, 3, and 4 pelvic splanchnics that will come back up the hindgut tube and meet up with it. If this, of course, is not possible because of the neural crest cells not migrating properly, then what's going to happen is you'll get Hirschsprung's disease. So these hindgut viscera and the pelvic viscera are supplied by these pelvic splanchnics from S2, 3, and 4 spinal nerves. Remember, they're axons that are projecting from the lateral horn of S2, 3, 4 spinal cord, and then they'll actually come off of S2, 3, 4 ventral rami, coming together and getting along this gut tube. The sympathetics, on the other hand, are more complicated. They have the sympathetic chain with ganglia at respective levels along the spinal cord. Now we're going to have T5 to T9 ganglia giving off some preganglionic structures, which are going to be the greater thoracic splanchnic nerves, and they'll distribute to the celiac and superior mesenteric areas, as well as giving off a small branch to the adrenal glands medulla. Then there's a lesser thoracic splanchnic that comes from T10 and 11. That's going to distribute to the superior mesenteric predominantly, and the least thoracic splanchnic, which will come around the renal ganglia. Some of the lumbar splanchnics will go around the inferior mesenteric, and then there'll be a few more that will drop into the hindgut towards the pelvis. Those will come off the sacral chain, and they're called sacral splanchnics. So we have thoracic splanchnics, lumbar splanchnics, and sacral splanchnics, all of which come from the sympathetic chain. And when the sympathetics come off, they can only really go a couple places. If they're going to the abdomen, they'll go around these para or pre-aortic ganglia. And if they're not going to these, then they have to synapse in the chain. Those are the only two options they have. So we've got a couple postganglionics that are distributing to the various components, and they'll make a plexus around, and some of these plexus will drop into the pelvis to supply sympathetics to the area of the pelvis and the hindgut. This is what it looks like in the netterized cartoon, and you can see how you've got greater thoracic splanchnics coming into the celiac ganglia. You've got them coming into the superior mesenteric ganglia around that vessel, and then you have a plexus of them as they go around and get to the inferior mesenteric ganglia. You can also see the lumbar chain ganglia off to the side, giving off lumbar splanchnic nerves. Anything that's not used up in this plexus will drop down into the pelvis, becoming known as the hypogastric plexus. Specifically, there'll be this superior hypogastric plexus around the bifurcation of the aorta. That can have some clinical ramifications in people that have an aortic aneurysm, because the repair of the aortic aneurysm can disrupt these hypogastric nerves around the bifurcation point, and this can lead to impotence in males because of the fact that the erectile nerves will come off of the hypogastric region. Here's an actual dissection showing all of this network of nerves and this plexus of structures going around the aorta, and then you can see the bifurcation point where they drop into the pelvis. So here's a summary of the autonomics of the abdomen. Parasympathetics are coming from the vagus and the pelvic splanchnics. I'll let you read about the rest of the details that are on this slide as far as the truncovagotomies, where you can cut that to cut down on the gastric acid and pepsin production. Also, you'll want to know that these pelvic splanchnics come off bilaterally from S2, 3, and 4 spinal mixed nerves. As far as sympathetics, the sympathetic chain has the sympathetics for the entire body. You must get into the chain if you're sympathetic. And there's going to be splanchnics associated with the different regions of the vertebrae. So in the thorax there are thoracic splanchnics, greater, lesser, and least. In the lumbar region there are lumbar splanchnics, which will come off the chain and supply the regional viscera in the abdomen. And they can go and synapse at the sympathetic chain, or they can do their second option, which is the preaortic ganglia. There's going to be a set of 4 paired ganglia in association with the sympathetic chain in the abdomen. Those preaortic ganglia are going to be celiac, superior mesenteric, aortic renal, and inferior mesenteric, which is going to be more diffuse. As I mentioned earlier, the superior hypogastric plexus will be all the remaining sympathetics that will drop into the pelvis to supply the viscera and the vessels in that area. They're known as superior hypogastric nerves, and these will drop into the pelvis to connect with some inferior hypogastric nerves, and then we'll have the innervation of the abdomen and the pelvis combined. That concludes section 29 on the abdominal vessels and the autonomics, and the next section will discuss the posterior abdominal wall